everyone, and thanks so much for joining us for today's episode of CHS Presents Health Connect. I'm Jane Hansen, along with my co-host, Dr. Patrick M. O'Shaughnessy, Catholic Health Services Senior Vice President of Medical Affairs and Chief Medical Officer. According to the CDC, chronic diseases like cancer, diabetes, obesity, and cardiovascular disease are responsible for 7 out of 10 deaths every year. Many of these conditions are caused by health risk behaviors like poor nutrition, physical inactivity, and substance abuse. Treating these conditions before a patient is in need of acute hospital care is just as important to CHS as caring for the patients once they've been diagnosed. And I'm assuming that's for a whole lot of different reasons, is it not?
Absolutely, Jane. And what you've just described is, in essence, population health management, which focuses around 3 critical, what we call the triple aim, which is improving the experience of care, both qualitatively and the patient's experience, making sure that the right care is delivered in the right setting and the right time and right place to give the best value, and then improve the outcomes of that care for our patients.
I'm assuming this has to involve a lot of education as well, because if you've got somebody who's got a chronic condition and they are continually encountering the same health issues, there's something wrong with the way that they're behaving on a daily basis.
Yeah, no question. There is the physical component, there's the emotional component, and then there's the behavioral component. And many times folks with multiple complex disease processes are really struggling. There's a lot going on in their lives. So really what we're focusing now is taking more of a preventative or a proactive approach in parallel to still being reactionary and treating people when they have complications of care. But the goal is to get upstream from those events and catch them earlier in their disease processes, with the hope of either delaying or perhaps sometimes even preventing diseases from occurring.
Sure. Now, I was startled by this statistic. Almost half of all adults, 117 million people, have one or more chronic health conditions. Is that a dramatic change from the past, or is it the way it's always been, we just didn't know it?
Well, you know, to the benefit of us all, we're living longer. And when we live longer, chances are you will develop some form of chronic disease. So again, as I mentioned earlier, it's really about having better touch points with patients. I mean, think about what we do with our kids, with pediatrics, right? We have well visits. They get immunized. We are aware of any little minor problem. But then, as we get older and we become adults, what happens? If you see your primary care doctor once per year, we consider that to be a good thing. Well, we need to really start to focus on bending the disease curve, and that will also work on bending the cost curve of healthcare. And that means people need to get in to see their doctors more frequently earlier, and then we need to develop better checks and processes to catch these early manifestations of chronic disease and try to divert that path.
So which are the worst diseases? I mean, what kinds of things? I know I mentioned in that lead-in, we talked about nutrition, obesity, all kinds of things like that. But what are the diseases that you really, in particular, are earmarking
Well,
for?
I mean, to your points earlier, the 3 major drivers, cardiovascular disease, cancer, and diabetes, with those 3 in combination encompass the greater majority of chronic disease processes. And then you put on top of that obesity. Many times that's a driving indicator for development of some problems such as diabetes or even cardiovascular disease, degenerative joint disease, and neurodegenerative diseases as well, such as Alzheimer's and Parkinson's. All of those are areas of focus for us.
And of course, we're going to talk a lot more about this during this course of this program. Catholic Health Services is focusing on population health to assist communities with the prevention of disease. We'll discuss this initiative today with Dr. Joel Schuh, Vice President of Clinical Transformation and Population Health for Catholic Health Services, and Anna Tenapel, Vice President of Care Management and Performance Improvement for CHS. Stay tuned to find out more about this progressive population health strategy on today's episode of CHS Presents Health Connect. Welcome back to CHS Presents Health Connect, where you live, work, play, and pray could factor into your overall health. And that is why CHS is moving beyond the walls of the hospital to assist in community wellness.
Joining us today to tell us more about population health management is Dr. Joel Schuh, Vice President for Clinical Transformation and Population Health for Catholic Health Services. Welcome, Joel.
Thank you. Honored to be here.
Good to have you here. Now, talk to me a little bit about what on earth is this title? Vice President of Clinical Transformation and Population Health. Is this a new role?
Yes, it is. About 2-3 years ago, almost no health systems had this role. And that was primarily because of the payment system and how hospital systems are reimbursed. And as the government has moved towards pay for performance, it's become more important to be able to manage groups of patients who have a commonality, whether it's their age or their disease status like diabetes, hypertension, heart failure, etc., and do it in a more cost-effective manner that improves quality while really enhancing the patient experience.
But wouldn't this be on CHS's part kind of a way of being more proactive versus being reactionary?
Well, I would say yes, and CHS has had programs that really improve population health. Unfortunately, they weren't necessarily reimbursed for it in the past, but now there are mechanisms by which, if we're able to improve patients' health and keep them healthy enough to not have to come to the hospital, then we can really stay in business.
You know, there's an old joke that I think people talk about all the time, which basically is, if you want to stay well, don't go to the hospital, because sometimes you can get sicker in the hospital. I know that that's not really true, but at times, I mean, there are things that can happen in hospitals that may not necessarily be healthy.
Well, there's no question. Hospitals are complex places, and I think one of the focuses that CHS strives on is really continuous quality improvement to make sure they are safe locations for care. But to Joel's points, what hospitals will become will be places where really we will be caring for the most complex and chronically ill patients, or those that need really a progressive invasive procedure. And really what CHS is focusing on, partly under Joel's leadership, is really expanding that ambulatory footprint and expanding preventative services in those areas.
So does that mean then, when you say that ambulatory footprint, what it actually means is there might be more kind of clinics where people can go to have certain kinds of surgery and probably more geographically attractive to them and all of that?
Exactly. Three major drivers for healthcare have and always will be quality, cost, and access. And so what population health management tries to do is really to assess all of those areas and improve them. And to your point, Jane, improving access by those networks are really going to help us improve the health of our population.
When you say population health, does that mean that you target, did you really take a look at who lives in certain areas and what kinds of diseases might be more prevalent there? And I mean, it seems really complicated.
We do. We develop programs that are really specific to what our population needs. So certain areas may have a higher prevalence of diabetes, so we're positioning diabetes clinics. Certain areas may have a higher prevalence of heart disease, and we position our clinics there. So we try to be responsive to what our population asks for.
So would you say this is like the latest, greatest thing in healthcare right now?
I wouldn't call it the latest, greatest thing. I would call it the necessary future of healthcare. Because as we know, costs are spiraling, and something needs to be done to better take care of people while remaining competitive in the world environment.
Now, would you be able to do this without all of the inroads we've made with modern technology?
I don't think so, because you remember, if you go to your physician's office, and each physician that you go to, you have to fill out your information all over again.
Which drives me nuts, by the way.
Yeah, I can understand that. And think about if you're really ill and you go to a hospital and no one has your records and you have to go through the entire process, get another x-ray, the same labs all over again. That makes it very difficult to be able to take care of you or to quickly understand what happened to you in your previous visits.
So with this technology, I think you've got a tool that you call clinical navigators. What does that mean?
Clinical navigators are a program that we're building that will connect patients to outpatient services and inpatient services as needed, because we really want to enhance the patient experience. The clinical navigator is going to have access to that patient's health records, understand what their disease processes are, and also know who the doctors are in the network. They'll also be able to tell them where x-ray services or other needed services might be, and when needed, they'll arrange for transportation for all the patients.
Jane, part of how I kind of equate this to where folks at home may have some connectivity here, navigation is really like the air traffic controllers. And so the providers may be the pilots and the co-pilots. You think they're the ones that are getting you safely to your destination. It's really air traffic control that's guiding them. And what navigation does in the clinical world is the same function. It just coordinates all of these efforts so it's one seamless program.
Well, it seems like then if you can actually get all of that accomplished, we could make some great inroads in helping people be healthier.
No question.
That's right.
So you were talking to me earlier about interventions and things like diabetes, how much money do you think something like this could save if you bring it down to dollars and cents?
So, when you look at diabetes, which is such a huge component of overall healthcare spend, as Joel mentioned, interventions that could delay onset of adult diabetes, as an example, could save the healthcare system $20 billion if you push that disease process back by 10 years. So if you were, not properly cared for and you developed diabetes, say at 40, imagine the impact to your quality of life. And I'm not going to say that we can prevent all disease, because we can't.
Right.
But if you just even delay that onset by 10 or even 15 years, it is a huge impact to that patient and their family's life. It improves quality, and it also will positively impact cost and decrease cost of care.
But what you're talking about here with all of this is that the patient, the person they really have to understand how to take advantage of this. And how do you do that?
Well, that's right. So you have to have people who can connect with the patients and speak in a way that they can understand. So we want to be culturally sensitive. We want to be multilingual and have the appropriate people who can relate to each population on their own.
And again, that education process means that they have to make some choices in what they do every day, too. They have to help in this process.
Absolutely.
So how do you convince them that that's the right thing to do? Because honestly, we all hear the stories, but unless somebody's right there, it's hard to kind of change your lifestyle.
Yeah, that's right. So we have to really educate our patients and make it easy for them, increasing access in a way that really makes it much more simple for them to go to the doctor versus going to the emergency room. So that begins with creating primary care practices that can accept visits on demand instead of several weeks in advance.
And then what does that do, though, to insurance premiums and the amount of money that people have to pay? Because that can get crazy.
Mm-hmm. Well, in today's environment, insurance premiums are going up, and that's a fact. But by more aggressively managing setting of care and doing preventative medicine, we believe that we can bend that cost curve back down, and eventually that'll go back to the people paying the premiums.
And are there things going in the future, things like tests like genome or whatever you call it, are there tests like that that could ultimately really help in this process? I mean, from when you're a young adult on?
Well, it's interesting, and I think, as many folks will comment on, probably part of the reason why preventative care has not gained momentum until recently is because there really wasn't a lot of evidence out there to say that we did have, in fact, improvement. Now, with some of the newer testing that is involved in getting patients engaged, it's called patient-centeredness, getting them engaged in their care, there is the ability to impact and make change. My parents were afraid to go to a hospital. They were afraid to go to their doctor. They didn't want to know what was going on. Now, it should be completely the opposite. You need to know what's going on, and sooner. And to your point, things such as genomics, imagine a test where as a young adult you can go in and with a blood test understand and know what you are genetically at risk for, and in some instances, when that deficit is found, it could be fixed. Now you've just changed the overall course of disease, and that is really where we're heading, to Joel's comments. It's really about being proactive as opposed to reactive, because the greatest cost of care is really when we're being reactive and at end-stage disease.
And is your goal ultimately to have hospitals be just very small places where only the most acute care, or even get rid of them altogether?
Well, many have been quoted as saying, our goals are to eliminate hospitals. We see hospitals as a vital part of our future for Catholic Health Services, but to your point, the types of patients that we'll treat in what's called an inpatient or hospital setting will change. And I don't know, Joel, if you want to add to that.
Well, our goal is to make sure that patients get the care that they need in advance of illness. And if that means lesser need for hospitals, so be it. The primary goal is to make sure that our patients are healthy.
And I think that's a great goal to have. We admire that. Thanks so much for being here. We're going to take a quick break, but we'll continue our discussion right after this. Welcome back to CHS Presents Health Connect. At Catholic Health Services of Long Island, the care and well-being of the community is provided before, during, and after a hospital stay.
Joining us now to continue our discussion on the importance of the health of our community is Anna Tenapple, Vice President for Care Management and Performance Improvement for Catholic Health Services. Welcome, Anna.
Thank you.
So what is this? Vice President of Performance Improvement? Is it your job to make sure everybody does what they're supposed to?
Yeah, it sort of is. My role at CHS is to work with all of our facilities. I work specifically with our care management departments, and I help ensure that they provide the best care for our patients and that the outcomes for our patients are what they need to be.
So talk to us about population health and how you're involved in that whole big program.
Well, population health and my involvement, one of the things I think of is the falls prevention program at Catholic Health Services. We have a big component of falls prevention focus, and one of the areas that we've been working with is with the Department of Health, the Suffolk County Department of Health, and we were able to train over 20 of our employees in a program called Stepping On.
And Stepping On is?
Stepping On is a great program. It's a CDC-sponsored evidence-based program that allows participants who engage in the program a 30% reduction in any type of fall if they follow the steps in the program.
Okay, go on.
So what it is, actually, it's a series of courses, classes, 1-hour classes, where exercise is brought forward about strengthening and balance training. And then there's some experts who come and they speak to the participants about medication safety, about occupational health safety and preventing falls by lifting carpets and various triggers around their home. And they also go over a really important aspect of fall prevention: medications.
Oh yeah, because people,
Oh, absolutely. And I think this is such a wonderful program because what we're able to do now is really to take these skills and education to the environment that we know we probably have the greatest impact, which is the home and outpatient setting, right? Because as an ED physician, I would see all the time, Jane, patients would come in already with a devastating injury or a fall, many times relating to an environmental issue in the house or polypharmacy, interactions of all the medications, or balance. So everything that Anna just spoke to has really provided, we think, great benefit to helping educate our teams to then educate patients on what they need to do to be safer in their homes.
You know, one of the things that for people watching this, you don't really think about that. Somebody falls. Really, how big a deal is it to do all this preventive stuff? But it's a big deal.
It's devastating. A fall can be devastating to the person who falls, and to be honest, they never really gained the strength and the abilities that they had prior to that fall.
Are you not just talking about the elderly, though, are you?
I'm talking about anybody.
Wow. So, in a fall, what's the most common or unknown reason that people fall?
Well, it's interesting you asked that question. There are several, and certainly tripping hazards such as rugs are a large one. But for people out there, remember, there are pets that are being tripped over and fallen, and people are arriving in our emergency rooms. Yes.
Really?
So the dog that's scurrying under your feet while you're preparing food in the kitchen is definitely a hazard.
So you've got this program called Stepping Out. You've got another program that's called POEM that's intended to help people stay out of the hospital. What's that?
We do. Our POEM program is very exciting. It's a program that's a geriatric fracture program, and it comes to us out of Good Samaritan Hospital currently. We're looking to extend it to all of our facilities. And what POEM stands for is Preventing Fracture, Osteoporosis, Education Management.
That's a big name. I'm glad you've taken it down to POEM. So how does it work, though? What's the context of it?
So what happens is basically a patient comes into one of our emergency rooms, or Good Samaritan emergency room. They have a fracture. We rapidly move them into the surgery suite. We take care of them surgically, and our goal is to move them toward discharge as soon as possible.
One of the other components, and what's so great about this program, is many times in the emergency departments, people would come in with a non-surgically needed to repaired fracture. They'd fall and maybe break their wrist, which could be just set in a cast. But we weren't connecting dots necessarily to say, does this patient have osteoporosis? Was this a low-impact fracture? And should we now be more progressive in doing some tests, such as DEXA scans, to look at bone density and other areas? And that's precisely what the program does. Again, in a population health forum, to try to really understand, is this patient at risk for the next fall, the devastating fall? That could be a hip fracture or something of that nature. If
you discover that they've got, that their bone density isn't what it should be, can you then treat that with medication?
Yes. Precisely.
And again, that might be a test they would not necessarily have had done.
Exactly.
But if they'd had it done, maybe even that wrist fracture wouldn't have happened.
Exactly. So many patients, they don't even know that they are having either early stages or are in fact osteoporotic until they fall and have that devastating fracture. So now we're training staff, and this is a program that the Good Samaritan team has done exceptionally well, to recognize these interventions. So if I'm in the ED and someone comes in with a vertebral body or back spine compression fracture, we don't just say, okay, that's, we'll deal with that one injury. We start looking for what underlying disease process could be occurring and try to prevent the second instance.
Where do you hope to take all of this, Anna? I mean, would you like to see these programs continue to expand?
Well, honestly, what we need to do is keep our patients out of the hospital. That's what population health is all about. So whether it's the POEM program at Good Samaritan or in any of our facilities, we have a very aggressive fall prevention program. When the patients come into our facilities, we have what we call a patient agreement, a falls prevention agreement, and we go over with all of our patients and all of our families how this is not the environment that they are used to at home. This is a different environment, and we want them to be free from falling. So we go over the importance of keeping their rooms clutter-free. We go over the importance of good lighting. We go over the importance of bringing everything to them that they need. And we go over the importance of them calling us when they need to move about in the room, if they need assistance. Patients don't often like to call us. They think that they're imposing on us, and calling for help is really important. So that helps us then prevent them from falling and keeping them safe in our facilities. In fact, we have a program in our rehab program that allows us to do some training before the patients leave. It's called Home Safety Education, and we're looking to get patients a little bit more familiar with making their home safe when they get home from their rehab journey, and then we can connect them into that Stepping On program that we spoke of earlier.
What about people that just in general should maybe declutter their homes long before any of this happens?
Well, that's a perfect example of someone who could really benefit from the Stepping On program. There's a whole initiative that the occupational therapist goes over about decluttering their home.
Rugs, all those sorts of things that can get in the way.
Pets, rugs.
Yeah. We don't want to get rid of our pets, though, because they're supposed to be so good to help make us healthy.
No, just get them out of the way.
Just not underfoot so you don't fall over them. Again, this is one more of the initiatives that you guys have, too, at Catholic Health Services to really kind of encompass that patient. What do patients tell you after the fact when they've been involved in this? What's the reaction?
So one of the things that the patients say about the Stepping On program in particular is that it's simple, it's easy, and it's useful. They really enjoy it, and they actually do recommend it to other people in their own community, which is excellent, and that's what we want.
Well, good work, Anna. Thank you so
Excellent
much for
work.
being here.
Thank you.
Thank you.
Appreciate it.
What all this is maybe really curious about now is, and recognizing this as a pretty new program, but the data about how you have helped people and prevented disease and prevented these effects. So how do you collect all of that?
So, it's great that you bring it up, and we're blessed. We have some incredible IT folks at CHS that are building out, again, using our integrated EMR. So
What's that mean?
So it's one record to one patient, one source of truth,
Okay.
everything in one system.
Okay.
And as part of that, those folks, in combination with folks like myself, Joel, and Anna, are really building out population health IT. And to answer your question, what that does for us is allows us to really develop analytics and also predictive analytics for our patients. So creating healthcare registries, say as an example, around diabetic patients or congestive heart failure patients. All these things, again, are necessary. They are foundational. We can't provide population health management clinically without having that data and having that interconnectedness of systems.
But at this point, is the real point of contact when somebody shows up at the hospital?
It could be when they show up in their doctor's office. Again, it's the same medical record. Now, we have other doctor's offices on other electronic health systems, and how you integrate that is into what's called a health information exchange. So all these EMRs fill in all this information to one repository so that people can get a better understanding of a patient's disease process, the interventions that they've had, and then how to make care better and safer for them.
The word safe that you just used, How about the safety of all these records?
They are very secure. And again, there are strict federal guidelines that we follow, and we have, in fact, the systems are so safe that many times I have a hard time even myself logging into them. There's such password protected security on it, but they are all very secure.
Well, so what's the ultimate goal in your head there here? What is it?
So the ultimate goal goes back to what I said earlier, which is really delivering the right care in the right setting at the right time to deliver the right outcome. And traditionally, healthcare has been focused in a reactionary mode. This is years ago. Patient gets sick or has a traumatic event, they're in a hospital. Now it's all moving to the ambulatory environment and even, as Anna mentioned, to the home environment. We have what is called a steep curve to climb in healthcare, and that comes from the Institute of Medicine. What is steep? It is we need to deliver care that is safe, timely, effective, equitable, and patient-centered for population health management. And that's our goal.
And a big chunk of that is getting patients, or everyone, not just patients, because everyone is a potential patient.
That's right.
And to getting all of them to understand what they need to do to participate in this.
That's right. The best patient is an engaged patient. And again, getting back to our healthcare system, we have a patient portal for them. When folks come into our facilities or a doctor's office, we try to sign them up on their smartphones so they could have access to their records. The more engaged they are, the better their outcomes will be clearly. And that's sometimes a challenge, as you've mentioned. Sometimes folks are not looking to be that engaged. For all of our viewers out there, it is the number one thing that you can do is to stay engaged in your own healthcare and that of your family.
Be your own best advocate.
Absolutely.
All right, thanks so much.
You're welcome.
That is all the time we have for today.
For more information, you can visit www.chsli.org or call 1-855-CHS-4500 for information about any of the Catholic Health Services of Long Island facilities.
Thanks again so much for joining us. We hope to see you next time on CHS Presents Health Connect.